it's only 6:32. Maybe we should wait another couple of minutes. How many
Yeah,
people
that's
are
okay.
on now?
We have 8 total participants, so I think that's maybe 5 people watching right now.
wow, we don't have many people here.
So let's wait a few more minutes. Miranda,
Okay.
how come it didn't get sent out as an email from the party?
Get what sent as an email?
The information about the meeting. It was just sent like yesterday as a text.
Yeah, so the system that we use, Mobilize, it sends reminder and confirmation messages. I think it's like 3 days out and then the day before.
Yeah, I was disappointed because 3 days out is pretty late to let people know about a meeting. But anyway, we're going to use this as a trial run to see. Do you want here? I don't know Michelle Ochoa, but she's in the waiting room. Should I admit her?
I admitted her.
Oh, okay. Okay, let's just wait one more minute.
I know.
Hey, Ken, there's 2 more people in the waiting room. Oh.
So it looks like Michelle Ochoa. Oh, there she goes. Okay.
Yeah, let's just wait till 6:35. Oh, now what happened? Who keeps changing this thing?
I didn't do anything.
It's so weird.
It's a computer. What do you expect?
So
Oh my
Miranda, are you
God.
leaving or staying?
I will be here for any sort of technical support. I'm just gonna keep my video off to not distract you
Wait,
all.
something got screwed up again.
Okay.
The thing I had it showing, and then now it's not showing. Oh, right.
So
Here we go. I got
yes,
it.
we can still see it.
Okay,
Yeah.
good.
Yep.
All right. So so why don't we get started? I know it's a small group. So you guys are going to be our sort of guinea pigs because we want to do this talk to more people throughout the state. And we'd like your feedback on what works, what doesn't, what information you need more of, what's not clear. So we really appreciate any and all comments. The reason that the 3 of us decided to give this presentation was there was some discussion about one of the resolutions about the direct contracting entities that Ken and I had introduced. And from the discussion, it was clear that people really didn't understand what that was. And we also felt they didn't really understand what Medicare for All meant. And it is a platform of the Pima County, of the Arizona Democratic Party. So we wanted to have a little primer for people on why we need Medicare for All, what the problems are with the current system, what some of the current challenges are, and how Medicare for All would be the only possible solution. So I'm going to start out with that first part about the problems with the current system. Then Marlene is going to talk about some current really significant threats to healthcare, and Ken's going to conclude with Medicare for All and why we think it's the only possible solution.
So Eve, if people want to ask questions, they can either put them in the chat or
Raise a hand.
raise your hand and one of us will recognize you.
Yeah, we want to keep it pretty informal. So when you talk about the U.S. healthcare system, many would argue that the U.S. system is actually not a system. And one expert said it is more a kaleidoscope of financing, insurance, delivery, and payment mechanisms that remain unstandardized and loosely coordinated. And that's to give it the benefit of the doubt, I think.
Really?
Because I would say uncoordinated, not loosely coordinated.
The kind definition.
Yeah. So how would you evaluate a healthcare system comparing, say, the US system with systems in other countries, because you need to know what the basis of comparison is. And the way I look at it is there's three attributes of the system, of a healthcare system. One is that people can access the system. The two is the quality of care they get within the system. And the third is the cost of that system, because all money that's spent on healthcare is not available to spend on other needs in our society, education and infrastructure, climate change work. So we can't spend all our money on healthcare. And if we look at the healthcare systems around the world, most of our countries have a single payer system. What that means is that the government is financing the healthcare system, but that it's privately delivered. In other words, the doctors are independent. There may be a role for insurance companies, but they're generally nonprofit and they're tightly controlled. And that's true in Europe and Taiwan. Canada doesn't really have a role for insurance companies, except to cover things that aren't covered by the regular healthcare system, like cosmetic surgery. The other approach of a single payer system is something like England, which is government financed and government delivered. So that is socialized medicine, in that the providers are employed by the government, as opposed to most other countries in the world. The US, on the other hand, has a market-based system, privately funded, privately delivered. It's also for profit, which really distinguishes it from most other countries in the world. It's employer-based, and there's reasons for that go back to World War II and wage and price controls during the war. But there is a huge role for government in certain populations: the elderly for Medicare, the poor for Medicaid, Indian Health Service, and the VA system. Now, if you look at the access that I mentioned in one of the attributes of the healthcare system, let's compare National Health Service, which is England. Basically, I think there's something missing on the left. I think those are different years. Basically, 100%, or maybe three different countries, 100% of people are covered. Where there's national health insurance, like Canada, also 100%. The all payer systems are some European countries where they have a small role for private insurances, but as I mentioned, they're very tightly controlled. That's close to 100%. So the US is the huge outlier in developed countries, and that only about 85% of the population is covered. Then if you look at primary care physicians, and the reason we talk about that is it's been shown that quality of care increases when there's a greater number of primary care doctors for the population. And again, if you compare all the other countries to the US, the bottom one, we're way below in the ratio of primary care doctors to specialists, only 30%, where in most of the other countries, it's more like 75%. Yeah, Marlene.
I just want to add on to that in the US, for at least the last 20 years, the percentage of primary care physicians compared to all physicians in the US is decreasing.
Right.
And that's a huge problem.
Right. And that's
out.
related to money. We'll get into that one later. And then if we look at the costs, so that was another attribute that I mentioned of a healthcare system. So there's the US, the big outlier, and these figures are 10 years old. So the numbers have gone up significantly. I think the US is up to something like over 10,000 per person, but they're relatively the same. So in other words, a country like England has less than half of the expenditures per person. The national health insurance countries like Canada have about half of the expenditures as compared to the US. So we are a huge outlier in cost. And this shows it in a different format, where as a percent of GDP, gross domestic product, which we're way over. If you look at countries like, well, the UK is under 10, we're at 17. I think we're up to 18% now, because this slide is a couple of years old. The average OECD, the Organization of Economic Cooperation and Development, that's the leading developed countries of the world. Average there is 8%. So we're double of any other developed countries. And yet, even in this country, we spend a lot of public money, as the programs I mentioned, Medicare, Medicaid, Indian Health, VA. We're already spending as much in government money as many of these other countries spend in total. And then the private adds on another significant percent. Now we talked about quality. That was the third attribute. How does the US do? Poorly. As this shows, life expectancy at birth, the US, you can see, has started to decline. This was from 2015. And many of you may know that with the opioid epidemic, that the suicide rates have significantly increased in the US, and the life expectancy has continued to fall. And then COVID really increased that. So the difference in life expectancy between the US and developed countries is increasing. Treatable mortality means those things that you could prevent by medical intervention. There again, the US is a big outlier compared to the other European countries because we don't treat preventable diseases very well. So again, National Health Service, socialized medicine, national health, Medicare for all, the all payers is like the ACA, but more extensive, whereas our country, most expensive. So it's financial cost, most uninsured, access, shortest life expectancies, quality of care. So we fail on all three measures. And even when people have insurance, the underinsurance rate has been increasing significantly. And this has been a huge factor in people accessing care because people are afraid to go to the emergency room. Walking into an emergency room now costs thousands of dollars. So people are, even if they have insurance, they're afraid to go. So this has been a huge problem, and something like 30% or more of the American population is underinsured for any significant medical illness. The other thing that I did want to mention is about racial disparities, and this was really apparent in COVID rates, which showed huge increases in Black and non-Hispanic white. Now, it's interesting, I just read that immunization rates in Blacks and Hispanics is now greater than in the white population. So we'll see an equalizing of those. And that's because they had huge community outreach, grassroots outreach efforts to reach those populations. But initially, when there was no vaccine, the outcomes for people with COVID were much worse in African Americans and Hispanics. So I just wanted to finish my part with this slide. Healthcare reform stalls in Congress. I'm just not seeing any good solutions. So why aren't we seeing solutions? Drug companies, insurance companies, and other companies, because we have a for-profit system with corporations in control. So I'm going to end there, see if anybody has any questions, and then turn it over to Marlene.
Okay, no questions.
Okay.
Okay, the first thing I want to do is explain what Medicare really is, because we're asking for Medicare for all, but many people don't understand what Medicare itself actually means, because our perspective in terms of Medicare for all is it's only the traditional Medicare perspective, not Medicare Advantage or direct contracting entities or ACO REACH 2023. And I just wanted to let people know that I really see this from four perspectives: as a Medicare provider, as a former Medicare Advantage medical director, before it was even called Medicare Advantage, and as a Medicare member, as well as a progressive who thinks we should have Medicare for all. So I want you all to recognize that it's not a single view that I have. So anyhow, right now there are four aspects of Medicare. Traditional Medicare with a Medigap insurance policy, which is Medicare A, B, as well as having to buy Medicare D, which is a prescription drug plan. Medicare Advantage, which includes Medicare A and B, and it's called Medicare C. It usually includes drugs, and then there's direct contracting entities, which I'll go into in greater detail. Next slide, please. Okay, basically, I assume everybody knows what capitation is, but basically Medicare Advantage plans are health plan options that Medicare pays the insurance company a set amount every month for your care. And which means that in many respects, Medicare Advantage plans are looking for healthy, well elderly, because they get the same amount to start with for relatively healthy, well older people. And they can save money by delivering fewer services to those individuals. Next slide. So again, here's just a quick distinction between original Medicare and Medicare Advantage Part C. How the Medicare Advantage plans try to get members by offering additional benefits like health club membership, which costs them very little, but seems to really drive a lot of people towards the Medicare Advantage plan. People can
healthier people.
Right, healthier people to a Medicare Advantage plan. So it has two aspects. It drives healthier people to the plan, and it gets people thinking, oh, they have a great deal. They sometimes do offer some additional vision benefits and some additional dental benefits, none of which cost the insurance company nearly as much as they're saving by driving healthy people to the plan. Next slide. In original Medicare, just so that you understand it, you can go to any doctor or any hospital that takes Medicare anywhere in the United States. And in most cases, you don't need a referral to see a specialist. In Medicare Advantage, Part C, and I was really astonished when I heard people at the state Democratic Party meeting say, oh, I have a friend who likes Medicare Advantage. And what people need to understand is you need to use doctors and other providers who are in the plan's network for non-emergency care. Some plans do offer non-emergency coverage out of network, but usually at a higher cost. And you may need to get a referral to see a specialist. You often need to get a referral to see a specialist. Next slide. I'm not going to repeat this, but if you guys want these slides, I'm happy to give them to you. Basically, it's in a little bit more detail than the original slide, which is the traditional Medicare policies versus the Medicare Advantage plans. Next slide. So when Medicare Advantage basically started, and actually it started before 2010, but this slide goes back to 2010, there were 2,300 Medicare Advantage plans. And by 2022, there's 3,800 Medicare Advantage plans. Remember, what Medicare Advantage does is put the insurance company between the patient and the provider. So there's somebody else managing your care, not the doctor. And I have to confess, when I first, 20 years ago, more than 20 years ago, worked in a Medicare Advantage plan, I thought, wow, this is really a pretty good deal, a pretty good thing for patients, because sometimes they provide social workers and case managers who sort of help keep people out of the system. Theoretically, it's for the advantage to the patient, but really it's to the advantage to the plan because it keeps people out of higher cost procedures, out of higher cost hospitalizations. So it's growing exponentially. Again, this is just the number of plans, not the number of enrollees. Next slide. And again, the field is dominated by a few insurers. The big one in this group is United Healthcare. They are really the gorilla of the group. Then there's Humana and then Blue Cross Blue Shield. Kaiser Permanente, that everybody talks about as a sort of an example of a Medicare Advantage plan, is relatively small compared to United, Humana, and Blue Cross Blue Shield. Theoretically, Blue Cross Blue Shield is not for profit. Next slide. Again, by the end of 2021, almost 50% of all Medicare enrollees and eligible beneficiaries were enrolled in Medicare Advantage plans. And again, these are usually the sort of well group on the top of the plan, because for all, you don't have to be 65 to be in Medicare, but you have to be physically disabled to qualify for Medicare if you're younger than 65. And they don't generally look at and try to enroll and market to people who are younger than 65, because they know that those are the people who have more medical conditions. Next slide. And this has been in the news recently. This was in the Times and on April 28th. It was just actually last week again in the Washington Post, looking at the results from the Office of the Inspector General, which is that Medicare Advantage plans deny needed care that should be covered to tens of thousands of people a year, federal investigators found. And again, that's all costing us our taxpayer money by paying these Medicare Advantage plans to deny care to the rest of the population. Next slide. This shows what things need prior authorization. The one thing that doesn't need prior authorization for Medicare Advantage are preventive services. And that's a good thing. There's nothing bad about this, but in general, things that older people, and I don't like to call them elderly because over 65 is just an older person, not an elderly person. Durable medical equipment, skilled nursing facility stays, Part B drugs, inpatient hospital stays, ambulance services, procedures, all of these things need prior authorization, which not only often denies care, it delays care. And delay of care is sometimes a huge problem because it can change the outcome of a condition. Next slide. And then people perceive that it's going to cost them less money. But if you look at this slide, the graph which shows the blue, there's 72% of a 10-day hospital stay requires cost sharing by the patient. So again, increasing the potential for medical debt, which is a huge problem in the United States. Next slide. Okay, this is another, I'm going to go briefly over this, but as a physician, this drives us crazy. Traditional Medicare, there's no incentive to code additional diagnoses. Medicare Advantage, there's a financial incentive to code more diagnoses. So you can get additional money if you have more diagnoses on the chart. It actually allows coders from the insurance plan to come into the office to scour the charts to see if they can find an additional diagnosis. So for example, they'll offer a patient an echocardiogram, which may show a mildly enlarged heart. And so they'll add on enlarged heart to the diagnosis, which will increase the capitated amount the insurance company pays, the Medicare pays the insurance company. And so these risk scores generated $12 billion in excess payments in 2020. That's $37 for every person in the United States. Next slide. Again, next slide. Again, there's no standardization, there's no nationwide coverage. You can only change your plan during open enrollment. And this is a really important thing that people may not recognize. You may not be able to change back to traditional Medicare if you sign up for a Medicare Advantage plan, because you can change back to traditional Medicare, but you might not be able to get a Medigap policy because, again, the Medigap policies are private insurance. They don't want somebody who has accumulated more diagnoses on a Medicare Advantage plan. Next slide. Again, The goal of the Center for Medicare and Medicaid at this point, or the government, the former Trump administration, is to privatize Medicare. So we have your Medicare card, traditional Medicare, Medicare Advantage, providers. There should be a next part of this slide. I guess it's not
That's
coming.
it. DCEs?
That's it.
Yeah, DCE. Not, I guess the way the slideshow is happening, you don't see it. Next slide. Okay, what's Medicare direct contracting and or ACO REACH? This is a pilot program which was launched late in the Trump administration. The stated goal is to reduce costs for Medicare, theoretically improving care for beneficiaries. The real goal is to change the way that Medicare pays for care. Instead of paying providers directly, it gives again a third-party middleman called a direct contracting entity a monthly payment to manage seniors' care. They are allowed to keep as overhead and profit what they don't spend on medical services, a new incentive to restrict care. Next slide. It's still a pilot project within Medicare. Next slide. It was started by the Center for Medicare and Medicaid Innovation, which is supposedly, again, a way to develop pilot programs to see if they can improve care and decrease costs. Next slide. It has no congressional approval. It's just an administrative decision made by the people who are running the Center for Medicare and Medicaid. Next slide. Again, they use upcoding to get higher monthly payments for Medicare. Next slide. Next slide. Again, the DCE engages primary care physicians. It capitates them for their primary care physicians' patients, and it maximizes capitation by driving upcoding. Next slide. They don't have their new data, but you can surmise from Medicare Advantage how the upcoding will be used. Next slide. Next slide.
You want to talk about this?
Well, they're basically allowed to keep as profit and overhead what they don't spend on medical services. Again, it's an incentive to ration and restrict seniors' care. They like to blame the cost of, they like to blame this on the doctors, but these decisions are made by the middleman rather than by the physicians. Next slide.
I just want to mention that when the ACA passed, it did limit the amount of profit that an insurance company
I'm doing
could
that in
make.
the slides.
Oh, sorry. Okay.
That's okay. Okay.
Oh, there it is.
Yeah.
Okay.
So here's traditional Medicare. The overhead is about, it's not even quite 2%, it's 2%. All the rest goes to patient care. 98% of the Medicare dollar goes to patient care. Medicare Advantage, the overhead plus the profit is 15%. 85% goes to patient care. And as Eve said, this was done at the behest of the ACA. Before that, actually, the Medicare Advantage plans and all managed care plans could make more than 15%. The REACH middleman has no limits. The overhead can be as much as 40 and profit as much as 40%, with only 60% going to patient care. This is the same dollars, technically, only 60% of what is spent is going to. Next slide. Theoretically, and this goes to what Eve was talking about in terms of the need to have equitable health care. Theoretically, there are equity incentives for underserved communities in this REACH plan. And basically, the REACH middleman has to simply report the demographic data. And then the middleman gets $360 per the underserved beneficiary, regardless of how much the beneficiary receives. And again, it does not necessarily provide additional care. It just uses demographic factors to increase risk scores and thus revenues. And these middlemen, these REACH plans are investor driven. So it can be Goldman Sachs, any private firm can develop a DCE. Next slide. And then I want you to look at check mark number 5, the DCE auto enroll seniors. So you may not know that you're signing up for a DCE. You just get, if your physician is on a DCE plan, the DCE automatically enrolls you. And then they may notify you that your physician is part of the DCE. Next slide. Next slide. And again, the only way you can not be on the DCE if your physician is part of the DCE is to change providers. You're allowed to change providers, that's not a problem. But if you love your doctor and he's part of the DCE or she's part of the DCE, you cannot stay with him unless you're willing to put up with the management of the DCE.
Sorry, I was looking at the chat and.
Yeah, I think that's a really important question. And how do you find out? Theoretically, you're supposed to get a letter, but that doesn't mean you will get a letter. And you basically have to ask them. And sometimes the doctor, if he's part of an accountable care organization, might not necessarily even know that the accountable care organization signed them up to be part of the DCE. So you can ask your doctor, but he or she may not even know. And I realized that I was just at my PCPs and I didn't ask my doctor. So everybody can make this mistake. It's really evil. And again, their goal is to increase volume, and Medicare states that the goal is by 2030 to have everybody on a privatized Medicare plan. Next slide. Next slide. This is a sample letter that you might get from your doctor, Sonda. It's really hard for people who live in underserved areas and rural areas because there may not be availability of other doctors. Okay, next slide. People complained bitterly about the DCE model, so it got changed. And in 2023, it's now going to be called the ACO REACH model, but it's essentially exactly the same thing as the DCE model with a new name. Next. And here's the best way to save your health. If you don't go to the doctor, he won't be able, or she won't be able to find anything wrong with you, and that's how you stay healthy. And sometimes that's true. I hate to say that, but unfortunately, sometimes that's true. I have additional slides, additional information. I think we should put in the chat how to get the petitions that you can sign that says you're against this DCE. We want you to reach out to Becerra, the Secretary of Health, to let him know that you don't approve of this, and we can send you some sample letters.
And also, I just met with Ann Kirkpatrick's staff and asked her to send a letter. So pressure on our federal legislators would be very helpful as well. So
Right.
Contacting her office or whoever your legislator is.
Thanks for putting that in, Ken. And again, I mean, I don't know what LDs are here or CDs are present in the room, but certainly Ann Kirkpatrick is for CD2. I suspect almost everybody in this meeting is in CD2. And one final thing before I turn this over to Ken, I just want to give a shout out to Sonda Schildman Park, who asked some good questions and who is also running for the state representative for Legislative District 19. And so if anybody's in Legislative District 19, I hope you'll be supporting her. Thanks.
Okay, so Ken,
Just
do you want me to
answer
move the
Jean's
slides?
question, Eve.
Say
ACO
again?
stands for Accountable Care Organization.
Say that again? Oh, you answered the question. Okay.
Oh,
Ken,
yeah.
do you want me to move your slides for you?
I think that'll work.
Okay. It's all yours.
So Medicare for all, who is it good for? Next slide. It's really improved Medicare for all. And what is it? Like traditional Medicare, it's paid upfront through taxes, but it's improved. There's no more premiums or out-of-pocket costs, more comprehensive coverage, and it's for all of us from birth to death. Medicare for all puts health care back in the hands of patients and their providers and makes health the bottom line. As you can see from the prior presentations, our current system, its driving force is what makes it profit. And Medicare for all would make the driving force what makes us healthier. So why is healthcare in the US so expensive? I think Eve touched on a lot of this, but 1 out of every 3 healthcare dollars is spent on administration and profit. And most health insurers operate to make a profit for their investors by charging the most and covering the least. And really, even those that are supposedly nonprofit have to compete with profit-making ones using the same model. So they just call it a surplus. We pay the highest price for healthcare and pharmaceuticals in the world. Next. Okay. Medicare for all is good for families. Families have health security. The comfort of knowing they can get health care when they need it without having to choose between needs like food and shelter and paying for care and medicines. I mean, I think it's hard for us in the US to comprehend how big that is. You know, since we don't have it, every time we have to deal with a medical system, we see dollar signs because we know that it's going to end up costing us a lot. And you know, one of the great fears, of course, is medical bankruptcy, but families no longer will have to worry about financial ruin or losing their home if a family member has an accident or an illness. Medicare for all means healthier families. Next. And Medicare for all is good for seniors. Seniors will have more comprehensive coverage, including dental, vision, hearing, prescription, and long-term care without having to spend down their savings before benefits begin, which is how it is now because you have to go on to Medicaid and you have to be practically destitute. No more out-of-pocket costs such as deductibles and copays. And I know we keep saying that, but it is so important because in the United States, many people, I think the number is between a third and a fourth of all people report not filling prescriptions, not getting tests, not following their doctor's recommendations because of the out-of-pocket costs that will come to them. So it's one insurance plan, and this simplifies work for doctors' offices. I mean, right now, the average physician is spending about $80,000 on people to deal with the insurance company in their office. And under a Medicare for all system, it's much simpler. There's not all these different plans with different rules. They just submit it to the government and it's done. I have a friend that was a physician in the United States. She moved to Canada and, you know, now there's like 3 doctors in the office and they have one part-time biller. But you won't see that in American offices. They're going to have multiple people doing billing. Medicare for all means better care for seniors. I said that. Okay, next slide. This is kind of a rundown of the menu. We can go over that one. Yeah, next slide. Now, things that are Medicare for all is good for workers. All workers would have the same comprehensive health benefits paid up front through a progressive tax. No headache of having to choose a plan or worry about losing it. And unions can focus on better wages and working conditions instead of the way it is today, where most labor disputes boil down to trying to maintain the health benefits. They don't even get to wages or working conditions. Workers would be able to change jobs or even retire early without the fear of losing health coverage. So Medicare for all means better working conditions. Medicare for all is actually good for business. Businesses will no longer carry the burden of providing health benefits for their employees. There is one comprehensive plan for everyone. Costs are transparent and predictable. Businesses will be more competitive internationally without being saddled with high healthcare costs that don't exist in other countries. So that's why Medicare for all will make businesses thrive. Medicare for all is good for health professionals. All health professionals will be included in one health plan with one set of transparent rules. Patients can go to any health facility or any doctor, so referrals will be simpler or not needed sometimes. Billing is simpler, saving tens of thousands of dollars each year in administrative costs for a health professional. Health decisions will be made by patients and caregivers. Medicare for all means healthcare professionals can focus on the needs of patients. Medicare for all promotes equity. Medicare for all, and I'm speaking specifically of the bill that is in the House now, HR 1976, which has 121 co-sponsors. But Medicare for all has the express purpose in the bill of reversing medical disparities. There are, again, no financial barriers to care, no premiums, deductibles, or copays. Medicare for all directs research and resources to improve health equity at the state and national level for medically underserved population, including designated funds to actually increase available medical facilities in underserved areas. No more networks as with Medicaid and private insurance. All people would have access to any provider or hospital. Medical debt disproportionately affecting people of color would be a thing of the past. As passage of the Medicare and regular Medicare over 50 years ago helped spur hospital integration and improve health access. Medicare for all will usher in true universal care. Next slide.
Ken, can I say one thing? I
So
want
really
people,
the bottom line. Yeah, sure.
people need to know that Medicaid, at least in the state of Arizona, not in every state, but in many states, is also managed care. So you also have a limit on prior authorizations and the way services can be improved for patients on Medicaid. So yes, if you fall off the income scale and you can get Medicaid, that doesn't mean you can get all the healthcare services you need, because you have Medicaid insurance companies, which are, again, are in the middle between the provider and the patient.
Right. So Medicaid for all is good for everyone. Medicare for all means everybody in, nobody out. Everyone can get care wherever they are in the United States. The risks of epidemics will be lower. With health as the bottom line, public policy can address public health threats such as unsafe food and poisoning of the air, land, and water. Medicare for all means better health. Next slide. But as Eve pointed to in her cartoon at the end, we have the reason that the United States does not do what the rest of the world does is because we've created this group of companies that are making tremendous amounts of money off of Medicare, off of healthcare. And their line is that it's a government takeover, it's socialism. But the reality is that with improved Medicare for all, providers, hospitals, and clinics remain private. Government just processes payments, becomes the single payer. Medical decisions will return to you and your doctor, not unnecessary middlemen with a perverse financial incentive to deny you care. That's what we have now. Next slide. So it's a nice little slide. I just want to point out that the numbers on the bills there have changed. The Senate bill is now 4204, and the House bill is 1976. But again, emphasizing there's no cost at point of service. You don't have to look at your finances before you go to the doctor. Next slide. So what can people do to help make this a reality? Continue to learn more about improved Medicare for all, universal health care, not only in terms of policy development in our country, but also how universal health care works in other countries around the world. Share your knowledge at every opportune moment. Family, friends, neighbors, and co-workers. Host a meeting of Fix It. It's called Fix It Healthcare. A wonderful video that really, explains a lot. And you can also do that at community groups and churches, civic associations. Become an engaged citizen and investigate your elected representatives' positions on Medicare for all. Meet with them, attend their town halls. Become active in supporting candidates for elective office that strongly support Medicare for all. Join or start a citizens group or organization devoted to the goal of promoting Medicare for all. Like in Arizona, we have the Arizona Medicare for All Coalition, and we'd love to have you join us. Invite speakers like us this evening to inform your organization about Medicare for all. Next slide.
That's it.
Oh, really? Okay.
That's all I
That's
have.
fine. Yeah, I had one other slide, but we can do without it. I think what I want
Oh, is
to...
that one?
No, that was
No.
I had some annex slides in case people
Oh,
had
okay.
additional
Yeah.
questions.
No. That's okay.
Okay.
I just wanted to add a couple things about Medicare for all. When I started using this slide set, there's some things that I think it leaves out. What does Medicare for all do basically is it creates a government system run, by a government public entity that bills, that pays the bills, right? And it prohibits private insurance from providing any of the services that are provided by the Medicare for All system. As Eve pointed out, they can, have insurance products to give cosmetic surgery or other benefits that they want to give above and beyond what Medicare for All gives. So I just wanted to make that clear about it. Questions?
Yeah, so questions, Judith?
I like to watch the Prime Minister on C-SPAN on Sunday evenings, and they're having a lot of problems because the current government keeps defunding some of their medical programs. So you hear their MPs talking all the time about Mrs. So-and-so, has had her surgery delayed 6 months. How would we prevent that from happening here?
Let me start out. So for one, we already have so many more things like CT scans and MRIs and surgeons that the issue of rationing would not nearly be as significant. And the other thing is, we have to realize how much rationing we have right now that's based on the ability to pay. So many people, as we talked in access, they don't have any access. So they're waiting infinity time because they can't go to the doctor. So I think that's important to point out that we have our own rationing that's very inequitable as opposed to some other systems. And the issue is how much money you want to put in the system. If you want to have people have access to life-saving interventions, which is true in most of those countries, they have their outcomes for things like end-stage renal disease, heart disease, is better than the United States. The things that people wait for, things like hip replacements, which is not an urgent thing, it can wait. So that's how you define what's important in your society. I don't know, Marlene and Ken, if you want to.
I was just going to add the OECD, which Eve showed some slides from the OECD. The OECD has data on many health conditions in terms of how the US fares compared to other countries. And we, in general, don't fare well in terms of other, compared to other countries. So, and like you said, you may have to wait a little while for non-urgent conditions, but I suspect it will not be a problem.
No, I'm a retired nurse, so I used to see our case managers going crazy trying to get coverage for our patients. And I also, unfortunately, saw patients discharged really before they should have been because Pam couldn't pull a miracle out of her hat. So I, for one, am all for Medicare for all. I think it's a right for every individual. And I think it should be right there with education, that it is a right. So that's my position.
I was just going to add that Ken's just sent out I think, when is your next meeting? July 7th, Ken?
July 7th, first Thursday of the month.
First Thursday of every month. And again, there's, and that next meeting, they're going to talk about privatization of that VA care, which is the next step that they would, it's not the next step, they've been working on that for a while to try to privatize the VA care.
Any other comments? Any thoughts? Was there some area that any of you thought we should explain more?
Sonda.
Yeah, I have a question. As a normal person, citizen, I'm really concerned about the DCE switching you without your knowledge. That reminds me of the Wells Fargo that opens accounts for you that you are not aware of. What can we do? Is there something that we can do to contact somebody to say,
yes, we have to contact your representative. Right now, that's Ann Kirkpatrick. You can contact your senator, and you can contact Becerra, and you can contact the White House.
Right.
Really?
And Sonda, as I said, we met with Kirkpatrick's aid about this specific issue just last week. So the more people that call her office, like now,
Okay,
the better, because they are aware of it. We sent them fact sheets. We've been asking her. We asked her to. There was a sign-on letter. She never signed it. That was back in the winter. So now she would have to send her own individual letter, which I sent her a copy of, so that more people call that office to
Okay.
get her to sign, the better.
okay,
There are
Okay.
now, I think, 57 representatives who have signed on against the DCE, but we certainly need a whole lot more, because it's really, I mean, it's money going into the for-profit sector. Into
it's
And
totally
pernicious.
terrifying. It's terrifying to me. Really is. That's from what I learned tonight. I mean, there's a lot of information, but this was the most scary to me, because you know, you are not involved in the process, and before you know it, you're in a situation that you really can put you into troubles.
Yes. And you don't know that until you need the care.
Right.
That's the problem.
Exactly.
Everybody thinks, oh, it's fine because if they're healthy, but as soon as something happens, that's when you find out it's too late.
So let me ask you a question. You're both physicians. Is it appropriate or inappropriate for me to send an email to my doctor, my primary care, and ask him if he's a member of the DCE gang or not? Is it
Yes.
okay?
It's totally
course.
appropriate. It's totally,
Okay.
Appropriate.
Yes.
Okay, because I'm going to do that.
Jean, did you have a question?
I just want to point out, I just put in the chat a very long link that will take you to register for our next meeting.
Okay.
And that's one of the reasons why I didn't respond as quickly, because I had to unmute myself and I had to switch screens. Do we have any draft letters that we can circulate to folks that we know that we come in contact with that would be interested in this? Also,
It was a sign-on letter for doctors, but non-physicians could sign too, that Physicians for a National Health Program promoted. Could somebody put in the chat the pnhp.org website? Because you can go to that website.
Ken already put it in the chat. It's in the
Oh,
chat.
okay. That has the link to the sign-on petition that went to Becerra and Biden. They've already delivered it, but they keep updating with numbers.
I don't see it anymore, the link.
one of the things,
I just put it in again.
Okay.
let me also give you my impression of this discussion here. You all are a specialized group. You know this issue backwards and forwards. I deal with a constituency that where Medicare is a very, very important to their well-being. They're not going to cling on to some of the rhetoric that was expressed in this thing. To me, it reminds me of when we were debating ACA under the Obama administration, and it was, what was Nancy Pelosi's great statement? We're going to have to vote for it before we find and pass it before we find out what's in it. And I'm looking for ways to explain this stuff that's very simple, very simple. The veterans were able to do that in terms of the privatization effort here, and that was they kept their message very simple. I'd like to do that with the folks that I come in contact with, a lot of the union retirees.
So you
Well,
want us to
what
make
part-
it simpler?
Go ahead, Marlene.
You want us to make the explanations more simple?
Well, what I'd like to do, I'd like to get a copy of the yeah, I think so. If you're going to take this out to the general, the non-practitioner audience, yes, I think you do want to make it simple. But I was going to say, I want to get a copy of the slideshow program, and I would try and do a simplification of it for my own constituencies. And I'll tell you right now, I mean, I deal with a lot of union retirees too. One issue that's very sacred to them is their union negotiated healthcare plans, and that has to be handled. I think one of the things I am going to do is make sure that AFL-CIO is in line with this. I hope they are.
Well,
Because
they
I've been
did,
a long time
the
supporter of Medicare.
AFL-CIO,
But I'd also like to say one other thing. It was my privilege to know a guy named Max Fine, who was the last surviving guy of the original Medicare task force. And he totally intended for Medicare to become, to apply to every
Universal.
American citizen. And that's one way I feel like I can contribute to Max's memory.
I think we almost need like the elevator speech
Right.
for a lot of folks who aren't, they're not as sophisticated about these issues. I know anytime I've talked about this, the first thing out of people's mouths are, well, this is socialism. Number one, I don't know why people are terrified of that word, but number two, to explain to them, like already we have some socialist things in this country, but to make it simple so they understand this is for their benefit. And that it's not the government interfering, et cetera, all those old arguments.
It's also for better healthcare too.
Yes.
I think it's interesting for people to know. I don't know. So for example, you're talking about Max Fine, who was one of the creators of Medicare. So right now, the Center for Medicare and Medicaid Innovation is headed by somebody named Liz Fowler, who is a former a former Anthem, which is the second biggest healthcare insurance provider in the country. She is now the head of the Center for Medicare and Medicaid Innovation. So we have the industry right there in the government making these decisions about how things should be administered. And I don't know, I mean, should people know that? I was gonna put it in and I thought, well, I haven't got enough time to go into that kind of detail, but maybe that's important for people to know.
Marlene, I got to tell you, when ACA came online, I was working with the district council, District of Columbia Council, and I was committee director. And let me tell you, we received so many phone calls from people who work for insurance agencies who say, hey, my job's on the line on this one. And it was.
Let me address that, Gene.
You can belittle it as much as you want to, but I'm telling you, it had an impact.
But the both bills have a huge section on retraining health insurance workers to come in the system to actually provide care if that's something they choose to do. So in both the Jayapal bill and the Bernie Sanders bill. So, and it has been done successfully in other countries that have converted to a single payer system.
Let me say this about that. I've heard arguments about that. I've seen slide programs on that. And if you're going to talk about retraining, you've got to show people what that pipeline is, and we don't. And I'll give you a good example of that. We had a meeting in Pima Area Labor Federation on the Green New Deal, and we got that point where it said, "This is where we're going to provide. This is how we're going to get jobs for people. This will create jobs." And what did they have? They had two people looking out over a cliff, and with AmeriCorps stamped all over their saddlebags. And my jaw dropped, and everyone else's jaw dropped when they saw that. So you've got to show how that pipeline works, and to get people to go on that, because you know, it's like Job Corps. Yeah, job retraining, what have you. Well, you know,
Yeah, I think it's a little different in that the just transition provisions in the Medicare for All bill, they provide a couple of things. They provide actual money to maintain your income for a period of time. And it's an industry where if you go to doctors' offices and you see all these young people working in the doctor's office, you know, a lot of them are medical assistants. They went to a training to do that, and then they find themselves doing nothing but pushing insurance papers around because that's the work that needs to be done. A lot of these same people, I've actually given a presentation to a group of medical assistants like this. They were more than happy. They jump at the chance to get a job in actual healthcare. And they would have preference. There would be people already working in the system for the insurance companies would have preference to get the training and the jobs that become available, because we're going to have to expand. You know, we have all these uninsured people. Yes, there'll be a lot more care. And yet, we never said this during the presentation, it will cost substantially less than what we're paying now. You know, estimates are like, if we go to Medicare for All, it's going to cost 32 trillion over the next 10 years. But if we don't, it costs 45. You know, the estimates. There was a study in the Lancet that showed that we could save up to $650 billion a year with Medicare for All and prevent many of those deaths, you know, from treatable causes that we have today.
I'm thinking that showing the slides of how other countries do it by providing that if more care with less money should make people see that the arguments by the insurance companies and many politicians are bogus, that saying it's going to cost more. Why would we screw it up and have it cost more when every other country has managed to do it for less? The other thing, Jean, I think that's a good point. We could add a slide, especially if we're speaking to an audience like union members, that discuss the kind of retraining parts of that bill, maybe go into the specifics of the bill. And what would be helpful for us is if we send you the slide deck and then you say what you think is the best, you know, make your own out of that and say what you think is missing, and we can help with that. So we can put together a slide deck that's more attuned to the audience you're talking about.
Sure, that'd be great. I'd like to.
And actually, maybe we, you know, originally the senior council of the state Democratic Party was going to have us present, and we decided to do this first. I think maybe we'll modify this and present it to them and see what their comments are too, in terms of the presentation. And that does have some union membership.
Yeah, it does.
In that forum. So that would be kind of interesting. I mean, there were sort of two real goals of this. One is to understand what Medicare is, because it's hard to explain what Medicare for All is if people don't even understand what current Medicare is. And two is to explain to people why it's important to have single payer universal health care. So there's really sort of two components to the presentation. And
yeah. Judith, you had a question?
I just gets back to what are you going to say? Like when I'm knocking on doors, canvassing, I usually have a list of things I want to talk about. So how can you boil down a rather complex issue into a few sentences? I mean, I'm thinking I would just say Medicare for All is good because it's cheaper, you get better care, etc. And
right.
Because
and I would say something about the corporatization of that everything's privatized in the US, and that only that money is going to private industry rather than to healthcare.
Yeah,
There's only so much money. So if it's going there, it's not going to be available for care.
I mean, I think I would definitely use I know the numbers right now for DCE, which is 40%
right.
goes to the investment firm. You know, their whole goal is to make profits for their stockholders.
Right.
I don't know offhand. No, I mean, that's the figure to use because of the ACA, you can only do 15% for the stockholders. But you know, 40% to the to the investors is a huge profit margin.
I took a lot of notes, so I think I can compress those into a.
Great. I think we should probably conclude the meeting. Marlene, can you say, because you had that in a document, do you want to send it to Jean?
Yeah, I'll send it to Jean. I'll send
Okay.
slides that we have to Jean.
Okay, and
Thanks,
you can let us
Marlene.
know how
Thanks,
we can help
Eve.
you.
That's what I
What?
want, more work.
And I'll look for the information for you about the retraining thing that I have from the pnhp.org website has a lot of that information analyzing the bill, the current bills.
Okay, that'd be
Talks about-
cool.
Okay, great. Well,
I
thanks,
just-
everybody.
Thank you.
Thank you all so much, because this was really a great presentation. Thanks.
Great,
Well, thanks
Thanks.
for coming.
thanks. So long, everybody.
Bye.
Bye-bye.